right, well, it is 5 o'clock on the dot, so we should probably go ahead and get started.
All right, I would like to really welcome all of you. I know this is an evening event and you've got plenty of things to do with your family and preparing for tomorrow's classroom time. But I do want to welcome you and introduce you to two of our panelists. One was Dr. Rowland and one is Dr. Mitchell, and they're going to introduce themselves as to their credentials and what they do with CHKD. But I just want to thank them for taking their time to present to us about COVID and as it relates to our children, and for that matter, as adults even. Without further ado, I'd like to go ahead and turn it over first to Dr. Rowland. You got to unmute yourself.
Thank you so much for having us. We really appreciate being here. My name is Dr. Leah Rowland, and I'm a general pediatrician at Pediatric Specialists. I've been working with the Virginia AAP on a state level on school reopening, chairing a task force where we have pediatricians come together along with our school nurse lead in the state, Ms. Tracy White, as well as Joanna Pitts from the VDH. And together we share ideas on what's going on throughout the state, look at the latest evidence, which is always coming out, and brainstorming together on safe school reopening and methods to do this. The other thing I've been working on is together with Dr. Mitchell, we've done some things with CHKD to try to be supportive as a community for school reopening. And we'll talk a little bit about that tonight. I've also assisted with Virginia Beach, and then a bit with Chesapeake and safe school reopening for those two districts locally. So thanks for having us today.
Thank you. Dr. Mitchell.
Yeah, hi, thanks. Again, thanks for having us. Hope we can provide some insight. I'm Doug Mitchell. I've been a pediatrician in the Norfolk area since 1992. I guess, what's that, 28 years. I'm currently a general pediatrician at Norfolk Pediatrics, part of the CHKD system also. I'm also the medical director for the entire CHKD general pediatric system, which is 20 practices with 31 locations and 140 docs. It's almost a second career. Before coming back to general pediatrics, I also did 12 years of pediatric infectious diseases. And I think that extra background in viral illnesses and epidemiology is why Dr. Rowland sort of drags me along with her to help with these sorts of things. As happens in any emergency or disaster, whatever you want to call it, there's a specific structure that you stand up in government and in hospitals, an incident command structure. And CHKD stood that up on March 4th, and I've been part of that central command structure for CHKD, hearing the various problems and problem solving for the health system. So I guess that's what I bring to the table tonight. So.
Thank you. All right, so what I'm going to do is put on my screen so that her presentation will be there. Before I do that, I just want to remind everyone, if you have questions as we proceed with the presentation, if you could hold those till the end so that she can, or they both can actually answer those. If a lot of times questions pop up, but it's already been answered in the presentation. So if we can hold them until near the end of the presentation and then put them into the question and answer section, that will help us. Did I say that right, Kelly?
You did a great job.
Okay, thank you.
Spokesperson for Hampton City School.
No, thank you. All right, I'm going to turn it over to this. Kate, can you give me access?
And before we get going, I'll say if I freeze in the middle of this, it's because I lost a new computer to a cup of coffee, because I do have 3 kids at home, 15, 13, and 9. So things happen.
Yes.
Dr. Mitchell's here to take over, so I do apologize ahead of time if my old MacBook doesn't come through for me today. But that's why I gave you the slides.
Yeah, so you should be able to share now.
Thank you.
So we just based this on questions that you all had submitted earlier. So we'll go through those and then if there's time. But yeah, I'd scroll all the way up to that first slide.
Yeah, sorry.
You're going to give it away. No.
I know, I'm so sorry. I was
I'm
reviewing.
just joking. Read fast.
No, keep your eyes closed, people. Oh, I'm so sorry.
I'm just teasing you.
No, I know you are. Thank you.
When I freeze up, then you won't hear from me anymore. Okay.
There you go.
All right. Next slide. We'll start out right with masks. So those of us in healthcare, for us, masks have always been a given. Just back one slide for me. And yep, that one. At what age should kids wear masks? So we started pretty early on at CHKD, masking 3 and up. And we've even been able to take that down to 2 and up. And the mandate just came out for the governor, 5 and up. But you know, anybody who sees somebody sneeze, we know these masks do something. And so for us in healthcare, you know, we don't go into surgery without a mask. I was always one of the lone folks that was always having one of those face shields with a mask all winter long for flu season when I'd have these coughing kids. It's just a natural protection. So there's really, kids are really good mask wearers. And we've seen this when we helped with Virginia Beach and Chesapeake opening, we got a lot of skepticism, but Dr. Mitchell and I said, just try it. These kiddos are better than grownups at keeping these masks on. And so we know that outdoors it's less important, but in the school setting in general, it's really best to just leave them on. The kids will forget that they're there. I think adults tend to focus on mask breaks more than kids do. They just forget about them. They're used to leaving clothes on and socks on and jackets and all these things that grown-ups tell them to do. So we've had a really good success in general. Mask breaks can be done when 6-foot spacing can be maintained, but I'd sort of leave that up to how do the teachers want to do that, and do they even need to be done at all? In general, we've emphasized water breaks, that kids just need to, you know, keep drinking the water that they have. So I'd sort of turn the discussion around to making sure they're getting enough water. And we as providers really try to fight mask myths because there is a lot of folks out there saying, oh, masks cause impetigo or skin infections on the face. They cause anxiety, fainting, exercising, all this stuff. And that is just not shown to be true, not in our practice anecdotally and not in the scientific literature. So next slide, please. I'll turn this next slide over to Dr. Mitchell, who can talk about the mask exemption that we've done at KD.
Sure. We decided again early on that we anticipated, and rightly so, that there was going to be a pushback on masks. And so we very quickly assembled a meeting of all of the pertinent subspecialists, the experts in the fields, to say, are there any medical reasons that kids should not be in masks? And the resounding answer to that was there are no medical reasons not to be in a mask. There are some behavioral reasons, and some of the, as you see there, some of the developmental delays, physical mobility problems, severe autism, or as our ENT colleague says, it's hard to wear a mask if you don't have an ear. You know, a little tongue in cheek, but that's sort of where we came at from this. And so the only exemptions, we created a standardized form. The only exemptions are really those severe developmental delays, or the occasional kid that has a tracheostomy, obviously. Every other reason they can do it, you know, anticipated pushback. Well, and I had one a couple weeks ago. You know, my children have asthma, and it's making their asthma worse to wear a mask. And the answer to that is no. The mask is not making their asthma worse. We need to get their asthma better so they can wear a mask. And because the other example is children with very severe pulmonary disease, and the same goes in adults as well. They're used to wearing a mask all the time, even though they have 10% of lung function. because that's how they protect themselves during regular times when they come into the hospital for their care. So really, the process we put in place, this is a standard exemption form that we have available, which has now been spread throughout the entire state. There should be limited use of it. The other thing is attached to that and available is guidance from our mental health folks of things we can do to reduce mask anxiety, to help with behavior changes and behavior modification, to allow the kids to be able to wear masks. And then the same thing, the exemption form doesn't say a kid should not and cannot ever wear a mask behaviorally for autism, but says they may have difficulty, continue to work with them. And whether you all want to go ahead and start enveloping it in the IEP to continue to work with the child to wear their mask and make gains along that way, that's a procedural question. But certainly if a child's able to tolerate it for periods of the day, they certainly can. We're not saying that they should never have a mask on.
And I would add that we've been watching how this has worked. This was created before any local schools were really open other than the private schools, because we anticipated with all the politicalization of mask wearing that there could be issues and just random notes written. So we created this to help protect our staff and teachers from people just deciding they didn't want to send their child in a mask. So we've looked at and been in touch with Chesapeake and Virginia Beach school systems to say, okay, how is this working? And in general, it's working very well. We haven't had a lot of problems. We've been sort of watching it, where are the concentrations of kids? Are there concentrations of kids who are not wearing masks? There really, so far, has not been any issue with this. Would you agree, Dr. Mitchell?
Yeah, to my knowledge, not from our side, there's not been a problem. I'm aware the schools occasionally have to answer it. The same thing, we, as a health system, our specialists and our general pediatricians are on the same page of, there's rare exceptions, and our role was to help encourage the wearing of the mask.
Next slide, please. So this was a question you all submitted to us, which has a lot in it here. And so we talked a little bit about inability to wear masks, that we could fold that into the IEP, but we would leave that to you. We would just encourage, if we did have to give a mask exemption for one of the few reasons we recommended, that would be incorporated into the IEP. The inability to answer the daily health questionnaire, we'll get to that in a minute, and the full physical assistance, should this population of students be returning to the classroom. So I think what we'll do is go through some of the pieces of this. I'll say on the first one, the significant underlying health issues, that's really between the family and the physician to decide those pieces to it, because there's a lot of families that come and see Dr. Mitchell and myself and say, do you feel, most of them have already made the decision to keep their child at home. I think there's very few that haven't made the decision. Would you agree, Dr. Mitchell, that portion of it?
Yeah, I think most have already been down that pathway. I mean, as the situations change, as we're seeing, we may need to revisit it for certain children over time. But yeah, we're far enough into this. Most of those have made their decisions already.
And I would say from the school standpoint, Ms. Glory could talk more about, the schools, but there's from the nursing standpoint on the state level, I know Tracy White has just a lot of guidance that she gives to all of the nurses and resources as far as how to set things up to care for children who have certain needs and things that need to be done at school, be it suctioning or whatever else. There's a lot of standardization and protocols for that from PPE to everything else that I would defer to her to discuss further. But let's go to the next slide. Oh, sorry, I guess I put them out of order. I apologize. That's okay. This is the mask exemption form, which we sort of, we alluded to already, but I would focus on the fact that, if for most folks, if they don't want to wear a mask and there's not a medical need for it, then they've got the freedom for virtual learning. And And then we can recommend extra protection, and that would be, through the nursing guidance for the staff that are working with those children who truly cannot wear masks and need to have a lot of close contact, similar to what we do at the hospital. So that, anything else you wanted to say with that portion, Dr. Mitchell?
I broke the rules of engagement here, and I noticed a question that's worth answering right now, and that is, what about claustrophobia? And I'll just answer that by saying that, again, our mental health folks have provided tools and resources to helping people overcome the anxiety of wearing a mask. And so I would encourage following those, and, it's helpful. There's methods to help overcome that anxiety and make it tolerable for everybody.
And on our school reopening website for the Virginia AAP, and probably also on the school nurses website, there's a lot of resources now about how to decrease mask wearing anxiety. And so that can be done at home and also through the school. So next slide, please. So symptom checks, this is a big one. And so, I know a lot of private schools are doing the symptom checks. Some of the public schools are. If you can click again for me. I would say in general, Dr. Mitchell and I have sort of agreed that temperature checks at the door really are not worth it. And I feel that there's enough scientific evidence to support this as well. If you go on the CDC and the American Academy of Pediatrics web pages, they really talk about how you can see how easy it would be for kids to congregate at the door. Not to mention, half the time these temperatures are not accurate. You might say, oh, am I really 93 degrees today? So for kids, it's just, kids don't have a fever. So I could see maybe doing this for the adults when they come to school, but really, a lot of folks don't necessarily have a fever, but especially children. So it also takes a lot of staff. And I feel really strongly, you guys have so much to think about already that, let's take away the things that are not really going to get your biggest bang for your buck. So a lot of the private schools just have, a lot more resources, and they can do symptom checks. But, in Virginia Beach, for instance, they have not been doing symptom checks. They've just focused on trying to educate everybody on what symptoms are, what to look for. And if you can click one more time for me, we really feel it's best to change the culture. So don't come to school sick. If you're a staff person, don't come if you think you're ill. And then the submitting forms online also really doesn't work, because anybody who's trying to get their kids out the door could easily say, oh, doggone it, I forgot to fill out that form. And it's, people can put whatever they want on the form. It's more important to have people understand why they shouldn't come to school sick and what the symptoms are, rather than fill out forms and hope that a infrared for the thermometer is going to do some good. So if it did do good, then it would be worth doing it. But it's really best to just focus on all the other mitigation that's been shown to be effective. Next slide, please.
I'm a little more blunt than Dr. Rowland is sometimes, that changing the culture. I mean, we're all aware, you all are teachers or school nurses, we're all aware of the parents that the child has a fever at 2 o'clock in the morning. They give them Tylenol, they get them up at 6, they give them another dose of Tylenol. They've got to get to work. They send them to school anyway, or they send them to daycare anyway. And then at 2 o'clock in the afternoon, they're in our offices because the daycare of the school kicked them out because their fever was back. That's the culture stuff that we've just got to get changed, and recognizing that if they've got a fever, you're out. And it's not suppressing the fever. That's where it's going to come, because we know that happens every flu season. And this is really just going to be a very prolonged flu season, as far as taking care of paying attention to fevers and staying home when there's symptoms.
So I like this graphic because everybody knows, you hear, well, cloth masks, they're not going to do it just by themselves. And so I think we can acknowledge that, yeah, it's not perfect. All of this, kids aren't perfect, staff's not perfect, nothing is perfect. But when you're trying to do when you're doing all of these things together, it really does cut transmission. And I would add several more layers on here, being cohorting, trying to keep the numbers of kids that are mixing down as far as the total numbers that are all congregating together, trying to get groups together, and then not having in-person staff meetings, ventilation efforts, if you know that's tricky depending on, but all of those things that you can do together really do cut down on spread. And so thinking about it this way, I think, is reassuring, because you know there's holes in the system, but when you put them all together, you see success. So next slide, please. Would you like to take this one, Dr. Mitchell?
Sure. What's the incubation time for someone exposed to COVID, and is it different in children than adults? Well, that the incubation time to symptoms can be anywhere up to 12 or 14 days before someone develops symptoms. And so that ties in exactly with if there's been an exposure, and you have to be careful about making sure you follow the epidemiologic definition of exposure. If there's been a true exposure to someone who's positive, that then defines the quarantine time of 14 days, because we are confident that anybody that's had a true exposure will develop their infection or the symptoms within those 14 days. And I don't remember if we had another slide, but it's also worth mentioning in there that, remember, just very similar to other viral illnesses, you can be contagious for 2 days before developing symptoms. And so anywhere in that 14 days, you can have someone with who's contagious with no symptoms at all, ever, or contagious with no symptoms for 2 days before they start developing their own symptoms. Is the incubation time different in children than adults? We don't have any evidence that the incubation time from exposure to development of infection is any different. Clearly, the severity of symptoms is different between children and adults, much less severe symptoms in children than adults. And so the adults are more likely to develop the symptoms, but the incubation time is not really different.
Great, let's go to the next slide. So children's symptoms, how do they differ from adults? Kids, fever, chills, cough, that's all, possibility with kids, but you read down this list and it can be a little bit of a lot of different things, which is why, if they have a couple of these symptoms, that we want folks to have a lower threshold for calling a pediatrician, coming to see us. I will say that the new loss of taste or smell is less common in kids than in adults. It's only 1% or less. And so when we at CHKD kind of try to decide who do we test and when do we test them, we kind of considered these symptoms and broke them down by weight a little bit. But I think the main thing is, if you've got there's the algorithms that I'm sure that many of you have seen from the VDH webpage, and I didn't put those in today, but they're certainly worth looking at. Next slide, please. Let's go back to the other one. Anything else you wanted to say on that? So the kids' symptoms run the gamut. I would say, especially if you've got a couple of them, or if you've got a singular fever or a singular new cough, or certainly an exposure, those are your top concerning symptoms. Do you want to pipe in, Dr. Mitchell?
Just there again, hoping to provide the support we could to the entire community from the pediatricians in the region. And that is, we also came out with sort of a algorithm, and if you will, a statement of who should we be testing, how should we be testing, so that every doctor is going to have their own approach. Every situation's a little bit different, but the more we could help standardize for the school nurses and administration to know that in this situation a child's likely to get a test before they return or not. So we did try and address that so that there wouldn't be a huge differing approach in the community. That always helps things too, if you know what's going to happen. So that was our attempt.
Next slide, please. And I saw this come up in the chat too. So, the big issue is what do we do at eating times? And so I think we try to spread out as much as we can. And I know that you're still looking at exactly how to do that. And just like in the school districts I've worked with, every classroom is going to be different. The number of kids in that classroom, all of those issues. I think a couple things to focus on. Number one would be, we want the teacher to be 6 feet away from all of the kids who are eating. I would focus on keeping your staff, away while kids are eating. For the kids' purposes, for contact tracing purposes, if you are within 6 feet for more than 15 minutes, you're going to be considered a close contact. But for actual transmissibility, as far as, well, how well are things transmitted, it makes intuitive sense that if you've got, and also scientific sense, though this hasn't been changed as far as the guidance, if you are 6 feet apart and not masked, how does that compare to 3 feet apart and masked? So if you're 3 feet apart and masked, kids are really doing well and they're not transmitting it in the schools that we've been working with, especially with the other mitigation in place. But contact tracing wise, the kids within that 3-foot radius would still have to be under quarantine. So if the kids are sitting next to each other and eating 3 feet apart, it's no different than them sitting 3 feet apart with masks on. Was I being clear, Dr. Mitchell? So from a contact tracing for kids, for a contact tracing point, whether they're eating 3 feet apart or with masks 3 feet apart, it doesn't matter as far as the contact for the child. But as far as protecting staff, if staff can sit further away and not, the spread that has been seen in schools across the country and internationally with staff has been primarily when staff are eating together, or in their home environment where they acquire it on a weekend or from a household contact.
Dr. Rowland, also with this question, we do have in place the desk shields. Does that help with the mitigation of while they're eating with their masks off, they have those desk shields up? Does that help in that?
I think that's a great question, and it hasn't been scientifically studied, but from a practical standpoint, because we really have to use our practical hats when we're in the middle of a pandemic, just because we know about how things are spread in general. This is, there are other viruses that we can look at and know what makes sense. So, and what they've used in the school districts we've worked with are similar to that. And I think it's not going to change the fact that that child would be considered a close contact, but practically speaking, when kids are reaching over and, trying to share, or they're sharing food, like, you want to avoid that. And so if there's something to kind of help contain things, it makes sense. I've also been, some schools have decided, including my son's school, to tell he's in 4th grade, tell those kids, okay, eat your lunch, and it's quiet lunch, and you eat your lunch, and when you're done, you put your mask back on and you get to have social time. And for the little ones, like, they're perfectly fine with that. They want to be in school. They're so happy to be there. I mean, as a parent, I was skeptical and kind of surprised, but it's actually, the kids are, they follow all kinds. You line up to the bathroom. If you have a star on your desk, you have to do this today, or, I mean, they're used to following all kinds of random things asked by them from adults. So I think, sorry, I got a little bit on a tangent there, but I would say that the shields, I think that will stop kids from messing with each other in the middle of lunch. But there's other things that you can do to try to really encourage them to just eat their lunch, then put their masks back on and be social. But feel free to pipe in, Dr. Mitchell.
The shields are one more example of that additional Swiss cheese. None of them is going to be perfect, but the more factors you put in there, the more you help the situation. The other answer to the question in the chat is that, you know, I don't live in the classroom, you know, so y'all have an opportunity to be creative and make new ground, whether you have only half the kids eating at the same time because you can't keep them separated, so you minimize the number of masks off, or you know, everybody goes to their own corner to eat or whatever, so that you can maximize the distance as much as possible. Just those principles, use the principles any way you can and be creative to minimize the close exposure with the mask off is sort of what we're looking at. The other question there, are you saying it's safe with a mask on 3 feet apart while you're sitting? No, I'm not going to guarantee anything. But the information that we know is that we dramatically decrease the risk of acquiring the infection with masks on, and we dramatically decrease the risk of getting an infection when we're more than 6 feet apart. In between that's a lot of gray area. And we know that we can, you know, if we can't do the 6 feet, then you got to have the mask on. If you get more than 6 feet outside, you're probably safe taking the mask off when playing outside more than 6 feet. But in between that, you're just doing the best you can.
And I would say, and I'm going to get to a little discussion about transmissibility, so we might circle back to some of these questions. As I think, you know, when we were first starting this whole journey, we were trying to figure out, well, how contagious is this really? Because it is, you know, I can understand. I mean, everybody, we're not making light of this, but I think it's really important to look at schools differently than the community, in that we have some experience now with schools opening, and it's really remarkable how well mitigation measures can work when all used together, and that it's not just so I guess we would say that in many schools, using all of these together and staying, you know, the 3 feet with the masking is really working as far as not having transmissibility in schools. But we'll get to that in just a minute. Can we have the next slide, please? I wanted to show you the return to school note that we, it's been used throughout the state as well, but we designed this at CHKD, and this was to try to encourage all of the healthcare providers in the community to follow the algorithms of the VDH, because you don't want a child just getting a random note, oh, you're fine to go back. And so I want you all to know that the community is really trying to support keeping the kids who need to be in quarantine or need to be home, or if they refuse to be tested, any of these things, that we're here to try to help keep them out of school, so, and not send them back to bring cases into the school. Is there anything you wanted to add with that, Dr. Mitchell?
No.
Okay, let's go to the next slide. So we want to talk a little bit about transmission in schools, and I first want to share this story. So next slide, please. There is a algorithm, not an algorithm, a dashboard on the VDH website about outbreaks of COVID. And I think we can learn something from looking at some of these. So I'm going to pick on one of them, not to pick on the school, but I think we can learn from this. Next slide, please. So 11 cases. Let's look at this particular school. Next slide. So we have to look at the context. So what was happening in Amherst at the time, and what were they doing in that context? So let's click on the next one. So, you know, they had some higher cases, and they had some higher, you know, PCR tests. And so, you know, the VDH talks about the ability of the school to implement the 5 strategies, but you know, they can't put that on their dashboard because only the school knows that. So if you go to this particular school's mitigation plan, click one more time for me. From the reopening plan, they say, well, we don't want students to require masks. They have language in there like, if parents insist on their child wearing a mask, they're doing singing indoors and other types of high-risk activities. They say, we'll try to accommodate 5 feet. So they're not even doing like no masks and 6 foot. They're doing no masks, and maybe we'll try to spread you out. They have extra people in the building. And so when they had this outbreak of 11, it was, they really weren't doing much of, not only were they not doing much of anything as far as mitigation, but they also were doing this within a context of a higher community level. And so if you've got so many, there's some mitigation that's give and take, because most schools cannot do a full 6 feet, but if you're doing all of the other things and you're together, then it really offers some protection. So let's see, next slide. But before I get into this
If I
part, I
may,
wanted
if
to
I
talk.
may add there too,
Yeah.
just to help clarify outbreak. That's sort of an epidemiologic term that's worth discussing. We know there will be positive kids in school. We know that. That's not a surprise. The difference is an outbreak is when it then transmits within the school setting, when you've got more than defined number of cases, and that's an epidemiologic definition done by our public health folks and the contact tracing to identify. So watching that the number of cases in a school or in a classroom is not all that helpful, because we know that kids are going to acquire it in the community from their homes, from their college age siblings who are partying in the bars and not practicing the mitigating factors we're talking about, those sorts of factors. And then they may be identified, but the issue is if they're transmitting it within the school. And in the schools in this region have been open, we've not seen that happening so far. That these prevention measures have prevented outbreaks, even though there's been sporadic kids that have been positive in the school.
So in fact, we've even been in touch with some of the local epidemiologists and health department directors who have been so impressed with the ability of mitigation measures to be successful in schools. I mean, we knew this back in the summer based on some international data, and also the child care centers who had been open throughout the entire time that schools were closed. We knew that transmission could be prevented, but to actually see that success happen in Virginia Beach and Chesapeake was really made a difference to the fact that, well, okay, so can schools stay open, and despite levels being higher? And so some of those conversations are being had, because we've seen single cases, as Dr. Mitchell said. There will be cases in the schools, because instead of being at home, a child is coming in. But if the child is not giving it to anyone, and we're seeing good evidence of that, that there have been all these single cases. You can look at Virginia Beach's dashboard and see 11111 all down the dashboard, but there's not spread happening, and that's extremely important and reassuring that the 3-foot spacing is working. And when you refer to children and the 3-foot rule, what ages does this apply to? The 3-foot came out of the World Health Organization, as well as the American Academy of Pediatrics, kind of trying to get a little more options for folks, and a little more that looking at some of the evidence. What ages would that apply to? I would say we're looking sort of through high school. And of course, high school, there's evidence that you have to be more strict with your mitigation, more careful with those kids. There's not a lot of high schools back necessarily, though private schools in this area are doing extremely well. I think there's fewer. I don't know if you want to make a comment on that, Dr. Mitchell, but I think that's probably an area of, but it's still 3-foot is what we're using for that, until we can show that less than 3-foot works as well. But we're not there yet. Any other comments you wanted to make with that, Dr. Mitchell?
No, no.
Okay, so the School Reopening Task Force, I just wanted to show you that, our website, and there's a lot of resources on there. it's mostly aimed at physicians, pediatricians, but there's a lot of different information if you're interested. I wanted to make you aware of that. But let's see, should we look at the chat, Dr. Mitchell? Let's
Sure, I'll
see.
take one. One is clarify yes, asymptomatic people can spread the virus. Kids are more likely to be asymptomatic, but they're also less likely to be contagious. Very clear information from the early school studies that the younger children are less likely to transmit it in the school setting, less likely to transmit it to each other, and less likely to transmit it to the adult teachers as well. So it's that reason we should not be afraid of that, but it's that asymptomatic spread that has prompted Governor Northam, I've known him for 28 years, to me it's still Dr. Northam, to encourage the universal wearing of masks, because we don't know who's asymptomatic and contagious out there. You never know, you just need to wear it all the time. The question about MIS-C typically is delayed onset. It's usually not so much when they're in the middle of being symptomatic, is what we've seen so far. So less contagious at the time it presents with the MIS-C. It's more of an late onset inflammatory process and less of the acute symptoms of the illness for the kids that have MIS-C.
And let's see, to comment on the 5 resources teachers coming into class, I think it's looking at, is there a way to do anything differently? Do those teachers really work with all of the students? I would say if the teachers are doing the mitigation that they're supposed to be doing as far as washing hands, and masking and staying apart if they can. It depends on what they're doing. I mean, which is why we can only say what the mitigation strategies should be ideally, and then they really have to be adapted on a school level. But I would say that one issue would be just keeping track of who's in the room. Will need to be done where you could just put a sign in on the door, and so you know who's in the room that particular day. But I would also say, looking at, well, how is this safe for the homeroom teacher? I would say because it really has been proven to be safe other places thus far if you're doing the mitigation well. So for instance, we've been taking care of kids since March, and we're not having, rampant spread with adults coming in and out of our offices all day long, parents coming in, and, like I said, some of the parents wear their masks not as well as the kids, but we're not seeing evidence of spread with all of these adults coming in and out of our offices. And we've done what we can do. We want our offices to be safe places. We need our kids to come in and get vaccinated. But I would say you can look to hospital systems as examples that, outpatient, not inpatient too, but outpatient are kind of good examples where people are there's lots of traffic and not rampant spread. And then the school systems that have been open, the daycares that have been open, all of that is evidence that you can move people that are necessary. You try to minimize, but you can move people who are necessary for the classroom to do what they need to do, and not have rampant spread. And that goes for, pre-K teachers. I would say also commenting on, we had a lot of discussion when the CDC changed their definition of close contact with the 15 minutes. We all said, where'd you get this from? And, 15 minutes cumulative, and the contact tracer said, just relax. We've been looking at this all along. And it was really just based on one interaction at a jail with a person who wasn't masked and another person who was. And so I would say in general, the pre-K teachers who are doing those things for kids, it's still very different than living in a home with someone who has it. And even living in a home, it's not 100% attack rate. We think it might be 10 to 20%. Would you say, Dr. Mitchell, is sort of what we're feeling right now in the scientific literature? We're learning more, but and some people spread it better than others. But the little kids in particular, because they're not asymptomatic, we think of little kids as just spreading everything. But when it comes to COVID, there's really been pretty consistent evidence that they're not spreaders in the same way adults are. Not that I'm saying they don't, we still have to do all the things we have to do, but I agree, dust shields are not always the answer. They're just one layer of the Swiss cheese. Did you want to say anything to that, Dr. Mitchell?
No, but looks like a couple of these next ones are more up my alley. And if you get it again, in what time frame? I mean, remember, we're in the US 8 or 9 months into this, so there's still a lot of information to be gathered, and that's what's concerning and confusing too, is that the rules keep changing. Keep in mind, the rules keep changing because we're gathering more data, and the more information we have, the more power we have, and we're trying to, in medicine and in public health, we're trying to adapt to the new information and provide the best resources and the best guidance based upon new information as we get it. So with that preface, that applies to, can you get it again? Right now we believe it's less likely. Certainly you've seen the reports in the media of somebody that's got it a second time. We don't know if, many other viruses you can get more than once, but we don't know what time frame. We do know the current guidance, the current data, and our current recommendation. And if you've had an infection in the previous 90 days and have symptoms again, we're not going to test you again, because at least in that 90-day time frame, there's no evidence it's going to be a repeat infection from COVID. So we're not doing that. Blood types, great question. I don't know. I haven't paid much attention to that one, but I'm not aware that it's showing any difference according to blood type. We do know the high risk groups. So if we talk about high risk groups for more likely to be infected or to have more serious infection, I mean, those are reliable. Obesity is definitely a risk factor. Age is definitely a risk factor. I'm probably the highest risk factor sitting in this chat room because of my age and because I'm seeing potentially infected kids every day in my office. And so there, by definition, I'm the higher risk group. We know it impacts minority groups, Black and Latinos more severely for a variety of reasons. So, the blood type is less than an issue, and those other risk factors are a greater issue. You've asked a great question. Can the other information be extrapolated to teens? We know the adults are more likely to spread. We know the young children in elementary school are less likely to spread. Good data on that. The report 3 months ago, time flies when you're having fun, shows that the high schoolers are more like adults. And so there again, the importance of really enforcing the need for masking. Many of those reports of frequency of spread were pre-masking before we had universal masking. And so, we can say pretty clearly where, CHKD is a fairly large health system. We've got several thousand employees, and we can say pretty comfortably that we don't have staff members that have acquired infection from treating unknown patients or treating infected patients by using proper PPE, proper masking. The risks have been from home exposures or exposures to others without mask. Eating close together in a staff break room without masking has been a greater risk for us than taking care of patients with our masks on. And I think I kind of answered that last one. Adult spreaders. High school is more like adults, but there again, most of that information has to do with without wearing a mask.
And I would say that some of the studies haven't really separated out the college students from the teens, which is not completely fair either. But it's sort of getting getting creative and really making sure that the high schoolers who might try to push it know that, no shoes, no shirt, no mask, no school. It just has to be an absolute, like wearing spaghetti straps or whatever else. You don't, mess around, like, and they don't want to be embarrassed. They don't want to be singled out. And I wouldn't, you have to make sure that that rule is instituted fairly among all students. That's very important, that certain groups of students wouldn't be, targeted or whatever, certainly. But in general, it should just be looked like a wardrobe issue. You got to wear it, and you've got to wear it right. And if you don't, then you have to be at home on virtual. So how important is sanitizing surfaces? I think that, well, would you like to talk about that? I saw you smile. I'll hand it over to you.
Oh, darn. Everything we do helps. Okay. But if you're prioritizing, I prioritize the distancing and the masking. But boy, do we sound like broken records here tonight. If you've got a choice between getting a kid to wear their mask or getting another staff member to wear the mask or having the time to wipe down the surface, go to correcting the mask. The hand washing to protect yourself is probably more important than wiping down the surface. Use that hand sanitizer, because the greater risk is coming off of a surface, not using hand sanitizer, or reaching up under your glasses or up under your mask or something like that. That's the greater risk. All of those are going to help. We do know there's plenty of evidence that the virus survives on surfaces. And so that's one more step that we can do to minimize transmission.
And one point with that too is that, there's all this stuff, we can detect the viral particles. Well, just because we can detect the viral particles does not mean that there's enough there to be infectious. So I think, norovirus, that nasty gastrointestinal infection, we know that thing is wicked infectious. It just takes 7 to 9 particles. But I would say that just to echo Dr. Mitchell, just because you'll read these studies, and that's why it's so difficult when you're trying to keep up on information and reading these news articles, that really read them with an element of skepticism, because a lot of times we'll go to the source study and find a lot of weaknesses in it. And I think some of the detection on virals on surfaces, is it there? Yes, but is it infectious? That remains to be seen. So
that's also the methodology of the studies that we're doing. Remember, again, one of those changing things was you had to stay home or stay out until you had a negative test. We've across the country completely dropped that requirement for a negative test. And that's because we've proven very clearly that the tests that we're doing, you see the PCR test, that's just looking for RNA, that's looking for chromosome. And we've proven very clearly beyond about 8.5 days after the onset of symptoms, that even though you might detect that RNA, it's no longer a transmissible virus. And so we've gotten away from a negative test before you return to just 10 days after the test, positive test, or 10 days after the onset of symptoms. Then you can safely return, and you don't need a negative test to return. And so school nurses, please don't ask that of us. It's not necessary. I know in the larger public schools are well staffed, that's not an issue, but we're getting that from daycares and smaller places that don't have the same resources for education that you do in the larger public school setting.
And I just want to end this by saying, if there aren't any more questions, I just want to end this by thanking all of you for taking care of our kids. And we're pediatricians, and so we're speaking up for kids, but we know we're on the same side that you are, and we just appreciate you all so much and want to keep you safe, and would not recommend school reopening or work on these things if we felt that it wasn't safe and reasonable to do so. So these layers of mitigation have really been shown to work. And the younger kids, I know you're looking at them first, and they're doing really well with that. But your safety matters and your comfort level matters. And I think all of the questions that you have should continually be addressed as new information comes out. But we've got a lot of more information than we had in July, which is great, which continues to show that this can be done safely and is possible to reopen schools. There was just a lot of questions back then, and many questions still remain, but we've really been pleased to see that schools are not areas of spread when these layers are done. We want you to be safe. We care very much about you, and we thank you. We see how kids light up when we ask them about their teachers and the well visits, and it's all about you guys when we say, how are you doing? How's school? Well, my teacher. And so we care about you all.
If I may add too, the reason that as pediatricians we're so motivated to help you do this safely is that the kids not going back to school, we are seeing long-term harm. And that's our concern as pediatricians. The fears are proving to be true in those long-term harm. The amount of depression and anxiety that we see in the office every day is disheartening. And it's getting worse day by day by day. The number of hospitalizations for suicidal attempts and suicidal ideation is just overwhelming our mental health care system. And it's the stress of what's going on, but it's also the stress of not having the kids in the classroom into their normal functions where they can socialize and interact with other adults and interact with their peers. So we want to make sure it's safe. We want to do what we can to enhance the long-term outcome of our children by doing anything we can to help you get them back in the classroom safely.
I thank you both. We're just about out of time, and I do thank you both for taking time out of your busy schedules to prepare this and to answer our questions. I thank Dr. Rollin for reaching out to me as well as answering my questions and things that we can do. And I look forward to still working with you, and as we have other questions arise, because they will, and we'll proceed from there. So again, thank you. And thank you for all those that attended. It shows me that we've got a great staff out there concerned and wanted to do the right things for our students and for yourselves. We do care about the protection of you as well, but we also wanted to present how our kids are going to fare through this, and this gives us some good support to proceed forward, just in making sure we're doing all the things that we can to keep that environment safe. So thank you again, both of you. And Kelly, do we need to do anything else? Kelly might have frozen. Anyway, I guess not. Everybody, thank you very much. Oh, there, Kelly's back. Kelly, do we need anything else that we should do? You're mute.
I lost you as you were finishing up. I apologize. My computer froze. No, I don't know what you said. I'm sure it was wonderful. But I really thank you so much for joining us and having this opportunity I know we've got principals on here and school nurses and counselors, and I believe social workers and teachers. So we've got a good representation from our school division. And I just, even though I've been in the weeds from the school division piece for safety mitigations and communication, this has been beneficial to me. I've really enjoyed the session this evening. So thank you very much.
Thank you. And everybody have a safe and healthy good night.